I'll be talking about when you're looking through the slit lamp, what do you look for subluxated? How do you identify subluxated cataract and vitreous in the anterior chamber? I'd like to thank AIOS and Dr. Saurav Sinha for giving me the opportunity. Yeah. So when the lens is displaced from its normal position in the pupillary area, that's when we call it a subluxated lens. And when this lens is completely displaced from the pupil, it is called as a luxated or a dislocated lens. Now, the term for congenital dislocations is ectopia lentis. Now, the dislocated lens can be in multiple positions. It can be incarcerated in the pupil. It can be seen in the anterior chamber or in the vitreous cavity. In the subretinal space, in rare situations, it might be wandering around, or it might also extrude out through the globe into the subconjunctival space. Now, the etiology over here is manifold. I'm going through these other aspects just briefly. It could be a congenital subluxation. It could be associated with metabolic disorders. It could be traumatic, or it could be spontaneous or consecutive. Now, the metabolic disorders, like we all know, the most commonly seen one is Marfan syndrome. Along with that, there are other conditions which might have associations, like Weil-Marchesani syndrome, homocystinuria. I won't be briefing about them though. Now, traumatic is the most common etiology that we see of lead subluxation. The mechanism is essentially a backward thrust to the lens and a rebounding of the lens. There's a pressure wave of the aqueous which forces the iris root backwards, and the vitreous body forcibly recoils, which then comes forward around the lens. Spontaneous or consecutive subluxation can be seen in inflammatory conditions such as hypermature cataracts, zonular destructions, enterocyclitic adhesions, or distraction bands. And mechanical stretching can also lead to it in cases like ophthalmos or patients with high myopia, with staphylomas, or intraocular tumors. Now, how do they present? The patient would typically present with a decrease in distance visual acuity, secondary to astigmatism or lenticular myopia. There might be decreased near visual acuity, secondary to loss of accommodative power. Visual acuity can vary according to the degree of malposition of the lens. There might be monocular diplopia. The patient might come with a red or painful eye. Amblyopia can be seen in cases of congenital ectopic lenses. Now, it's very important to note down the history, the onset, whether there is any associated cardiovascular disease or skeletal disorders, any history of ocular trauma, any family history which details of consanguinity or mental retardation, or unexplained deaths at a young age, which can be associated with systemic conditions. Now, even before going to the slit lamp, on retinoscopy and refraction, one can get an idea of subluxation, wherein an edge of the dislocated lens may be identified in the pupillary space. There might be a high myopia with astigmatism, and keratometry can assess the exact degree of corneal astigmatism as well. Now, on ocular examination, there might be possible megalocornea. The anterior chamber will generally be irregular. It could be flat. There might be cells and flare indicating uveitis. Vitreous may be seen in the anterior chamber. The anterior chamber angle is very important to assess that. There might be angle recession, especially in cases of trauma, and synechia might be found over here. The iris might show iridogenesis. There might be transillumination defects. And the pupillary area must be nicely assessed because the aphakic area can give an idea about aphakic correction. It's important to look at the lens position, whether there is any phacogenesis, whether there's associated cataract, what is the status of the zonules, whether they are stretched or broken, because it's going to be important while taking a decision on the management of the patient. One must also look for pseudo-exfoliation. Now, in cases of mild subluxation, the lens edge generally uncovers 0 to 25% of the dilated pupil. When there's more uncovering of 25 to 50%, that is called as moderate subluxation, or severe subluxation when the lens edge uncovers more than 50% of the dilated pupil. Now, in cases of dislocation, when there is an anterior dislocation, generally we'll be able to see a clear lens which has an oil droplet appearance with a golden luster of the rim. It might be cataractis, there might be iridocyclitis, there might be endothelial damage, there might be a raise in intraocular pressure leading to secondary glaucoma. In cases of posterior subluxation, the pupillary area will obviously be aphakic. The lens might be seen in the vitreous cavity. It might also be picked up on an ultrasound B scan in case if the media is not very clear or in case there is associated bleeding. There might be vitreous in the anterior chamber. Corneal endothelial status is very important to note that, and there might be corneal vitreous touch as well. Now, if there is a vitreous blob in the AC, how do you essentially look at that? So you look for the anterior vitreous phase on the slit lamp, and it can also, you make a thin slit beam, and you might also be able to make out pigments in the anterior vitreous and on the other anterior ocular structures, such as the endothelium or even the lens capsule. So that can give an idea that there is vitreous over there. So any other subtle signs? Yes, we can look for pupil peaking. The anterior chamber depth would be irregular, and there would be tilting of the anterior lens slit. One can also make an oblique illumination slit beam and ask the patient to gently move the eye in different directions, which it's going to make it very easy or simpler, much more appreciable to see the movement of the vitreous on ocular movements. Now, obviously, a fully dilated evaluation must be performed. It is also important to note the amount of vitreous and the location. Like I said before, there will be raised intraocular pressure, which may lead to secondary glaucoma. One can see that one can also have pupillary block, which might lead to a very painful eye. There might be phacolytic or anaphylactic reaction. There might be post-traumatic angle recession. Also, one can also, in cases of metabolic conditions, one might be able to differentiate poorly developed angle structures. A dilated retinal examination is very important. One can make out retinal detachment, retinal tears, vitreous hemorrhage might be found, optic nerve changes or macular edema might be found, intraocular tumors might be found. So various complications that can be associated with these conditions are glaucoma or corneal decompensation, uveitis, amblyopia, or retinal detachment. So when do you intervene? When a patient is symptomatic, when the patient does complain of progressive vision loss, when there are signs of high intraocular pressure, and there is endothelial decompensation. So what about the management? I'm going to just briefly talk about this in a few slides. So obviously, the first stage of management would be to control the intraocular pressure if there is secondary glaucoma, if there is a lot of inflammation, then controlling the inflammation, and then the definitive intervention would either be spectacle correction or surgical intervention. Now, in cases of subluxated lens with vitreous in AC, there are two options. It can be a clear lens or it can be a cataractless lens. If it's a clear lens and if it's a minimal subluxation, spectacles correction through the phakic portion can provide relief. If it's a marked subluxation, then surgical intervention is what is going to be required. One can either tackle it with the pars plana vitrectomy, lensectomy with IOL implantation, or through the limbal route, wherein a phacoemulsification with iris. Sorry, sir?
No,
shall I proceed?
Yeah, carry on, Piyush. That is just telling you that time is almost over, but you can make your conclusion.
Sure, sir. If the in cases of patients with the subluxated lens where the lens is cataractous, and if it's minimal, then in that situation, an anterior segment route, wherein an ECC or an SICS or phacoemulsification with anterior vitrectomy with IOL implantation can be planned. In case if it's marked subluxation, then in that situation, either do in a pars plana lensectomy with vitrectomy, or you go in and through the limbal route and do a phacoemulsification with the help of iris hooks and put in an IOL. Now, it's also important to note the amount of subluxation because it's going to have a bearing on the management. If it is less than 3 clock hours, obviously one does a slow phacoemulsification with PCIOL. If it's a 3 to 5 clock hours, you do phacoemulsification with the capsular tension ring or a CONE ring segment with a PCIOL. If it's 5 to 7 clock hours, you along with phaco, you put in a CONE fixation ring or an emerge segment with preferably a PCIOL. More than 7 clock hours, it's preferable to do a lensectomy with vitrectomy through the pars plana route and SFIOL or a blue IOL. In any case, depending on what the surgeon assesses, you can always go in for a lensectomy vitrectomy with an IOL. So in conclusion, my take-home message would be it is very important to elicit a good history in such cases. If the history arouses any suspicion, then look for specific findings in the anterior segment, as I've already discussed. Pay attention to the subtle anterior segment changes because this is going to decide whether you must take up the patient for surgery immediately or you should wait. And the timing of the surgery and the management is very crucial over here. Thank you very much.
Thank you, Dr. Piyush. That was a fantastic algorithm of how to manage a subluxated cataract or a subluxated lens. Any questions from the chair for Dr. Piyush before we proceed?
Dr. Piyush, can I ask you a few queries? And congratulations for a wonderful presentation, first of all. So, there are two scenarios which we encounter in our general practice. One is there is a patient who has come with trauma. He was having a good vision, and now he has developed an subluxation, and his best corrected visual acuity with cylinder correction around 3 to 4 diopters. He gets a vision of 612, 6.9. So what will be your take? Will you give him the spectacles and go, or ask him to undergo a surgery in this era where we are very comfortable with SFIL or other modes of treatment? And my second question is also one more question. In your last slide, you said that
then we move on to the second question.
Yeah, only two questions. In your last slide, you had said that in 7 clock hours, I would go for a pars plana lensectomy. Any opinion about you regarding going for an anterior approach, or you always approach it through a pars plana? You'd like to do an ICC?
I'll take the second.
Okay.
Yes, I'm sorry.
Would you like to do ICC or something like that, or you always go for an PPL?
Thank you for the questions, Dr. Abhishek. Now, me being a retina surgeon, I am more comfortable in the vitreous cavity as compared to going to the anterior route. So, frankly speaking, yes, if it's a large subluxation, I would probably go in for and do a lensectomy with vitrectomy. If my anterior segment surgeon, obviously, I would take the help of my anterior segment surgeon as well. And if they're comfortable in going ahead and doing surgery through the anterior route, I would definitely want that to be done. In case if there are complications, then I would be there as a backup surgeon and probably take care of it. For the simple fact that the results, post-operative refraction, the chances of any further complications, unless if we can avoid entering the vitreous cavity, would be better. I think that's the second part. The first part, or first question that you had was, if I remember correctly, it is if you have a patient who can be corrected with a cylindrical number, would you still take up that patient for surgery? I think we have to consider a couple of factors over here. It is the amount of subluxation, whether there is any vitreous in the anterior chamber, whether the cornea is showing any any decompensation, what was the inflammatory status, whether there are any associated retinal complications that are there in such a patient, whether there is any intraocular pressure rate. So all of these factors considered, if all of them seem to be fine, then we don't need to rush and probably go in. Another important thing is the etiology. Sometimes you have these kind of subluxations associated with metabolic conditions, and you don't need to rush in for surgery in such situations. So only when there are secondary complications, that is the time when surgery immediately would be warranted.
I think fair enough. Good answer.